like every bump.
You're
like,
missing it every time.
Buddy, keep quiet down. I'm trying to teach these guys about not angry. What's the most commonly misdiagnosis?
The second.
The second.
You are listening to EMS with your hosts, Erik and Matt Ball.
What's your ultimate cognitive bias story? Do you have one?
Well, the first thing I'm thinking is today.
Oh.
You guys called me out on some cognitive bias.
Oh, yeah. Our film guy, Devin.
Yeah. Devin, our media director, he and I, we were all talking.
I was in the right file, Devin.
Right. I was sure that I was in the right file. And I think this would be confirmation bias. And even though he was presenting the correct information to me, I totally disregarded him because I was so sure that I was right.
Is that part of your concrete brain? Like, do you think that's part of that?
Yeah, you know what? I think you're right. This is now, that's called, that neurodiversity. Our brains function a little differently, and I am more at risk of falling prey to this type of bias because of the way my brain is wired.
Yeah.
Whereas somebody else might be more innately curious.
Right.
When they get new information.
Or open to, maybe I didn't do that.
Yeah.
Let me double check.
My wife just says I'm stubborn.
Well, that's what wives do.
So what are we talking about today?
Cognitive bias.
Cognitive bias.
Yes.
And the thing I like about this talk is something's very useful for all of us, regardless of your level of care, regardless of your expertise, whether you're listening to this and you're an ER doc, a nurse, a paramedic, an EMT, a brand new student in any of these fields.
Yeah.
You couldn't even be listening to this and you're an accountant, nothing related to medicine at all. And this will actually be a benefit to anyone.
Yes.
And regardless of age too. I mean, adolescents in school might be able to recognize some of these signs and move past them. But within EMS, the stakes are pretty high. We're dealing with patients' lives. And so I think this is something to really talk about in our industry.
It's definitely a problem. I don't know about a problem. It's definitely something we need to be aware of.
Yeah.
And it's important to know how our brains work. And because it will alleviate problems. We talk about, a lot of times, we'll talk about having a checklist or something, and sometimes people will get a little bit offended, like, well, I don't need a checklist. I've been doing this for 20 years. I don't need a checklist. And like our medical director always says, like, pilots use checklists all the time. Yeah. And trust me, they train just as much, if not more than you do as a paramedic. They might have thousands upon thousands. Sullenberger, when he had the Miracle on the Hudson, that guy was a very experienced pilot, and still, when he encountered an issue, to make sure that he wasn't using or falling into cognitive bias, he pulled out his checklist and he went through, okay, have we done this? Have we done this? He went through all the steps. And so it's important that we don't, and we'll talk about, because I didn't realize there's different types of cognitive bias, overconfidence. That can be a certain type of cognitive bias where you think, oh, I just know what I'm doing, right? Or the Dunning-Kruger effect, which we'll talk about. Yeah. So there's all different types, and it's important for us to know those so we don't get caught in those traps.
And it actually can be a benefit to us too, because in some ways we need to have these systems in place where we recognize patterns, and then we can move on those patterns, and it becomes something that is a process.
Right.
The problem is with cognitive bias, sometimes it's hard to divert from a process that you begin for various different reasons. So I think you kind of hit the nail on the head with System 1 and System 2.
Yeah. Yeah, well, that's not my idea. We've talked about that before. That was that Thinking Fast and Slow book by Daniel Kahneman. I hope I'm saying his last name right. And he just talks about the System 1, System 2 thinking, how System 1, 90+% of our thinking is System 1 thinking, right? Yeah. You're driving in traffic and the car in front of you slams on their brakes. You don't have to process that information. You slam on your brakes. That's System 1 thinking. It's muscle memory. It's automatic. It takes very little effort. And then you have your System 2 thinking, which is you're going in to take your MCATs or your National Registry exam. Now you're slowing down and you're really concentrating and focusing on information.
Yep. And it's tempting to stay in the System 1 way of thinking. It's easier,
fast.
It's comfortable, it's fast. Yep. And part of our job in EMS has to be fast.
Yes.
So it's tough sometimes to know when to slide out of a certain process or System 1 way of thinking to get into System 2 to maybe redirect into a new line of thinking. That can be really difficult. The reptilian portions of our brain don't like change. Then we've talked about this too. This plays effect in this in a tremendous way, where you don't like the change.
Amygdala, change in the way things are. Right?
That's right.
It's actually scientific why we don't like that.
That's exactly right.
Yeah.
And we all like easy.
Yeah.
We love easy.
Comfortable.
Easy.
Yeah.
It's dopamine.
Yes.
Easy. We like scrolling. We like Netflix. We like ice cream. It's an easy high.
Yeah.
And when things are easy and simple and they're not changing, we feel good.
Yeah.
Sometimes, however, we have to make changes, and that's uncomfortable. It's a pretty neat process to look at the brain and how it does that.
Yep.
Matt, if you wanted to go climb, you work out. You and I both, actually. We work out in the morning, pretty consistent. And it would be a lot easier to just take a nap.
Oh, yeah.
But we actually do something a little bit difficult, and we get to the gym, we work out, and we do it for a reason, for long-term benefits, right? Well, going against the grain does this cool thing in your frontal cortex. Deep in your forehead there's this area of the brain that gets bolstered when you do things that are a little bit difficult, and you have that delayed gratification for long-term gain.
Right.
Strengthening that area of the brain is got huge benefits, and actually they've done studies on this.
Yeah.
And you really mature that area of the brain, then you've got a greater ability to endure trials and adversity.
Yes.
And I think that's concerning too. Today is such an instant gratification
for sure.
world.
For sure.
We don't have a lot of that toughness.
No.
Because you got to build that. It's a skill. And I think cognitive bias is the same way to bring it around. If we're aware of these cognitive biases, we're able then to recognize them, like you said, being aware. Then we can actually do something about it and recognize the potential problems.
Yeah, I think with the system 1, system 2 thinking, we want to be we're going to be in system 1 automatically, right? Because that's where our brains are going to go. The system 2 is having that checklist, right? Like we teach people about the 6 R's of medication administration, right? You're going to give a medication, Zofran, 4 milligrams, right? We've all given it hundreds of times if you've been doing this any length of time. You don't really think about it. You certainly don't focus on that as much as you do when you're about to push ketamine and rock, right? You're a little bit more honed in when you're given those type of medications, right? But system 1 is patient's nauseous. We got to give 4 milligrams of Zofran. Again, if you've been doing this any length of time, that's almost an automatic system 1 type thought. But it's always good that system 2 is go to your 6 R's, right? And make sure this is the right patient, that you're giving the right dose, that you're double checking. And one of the things I would always train my new paramedics, and I always did, to alleviate a mistake, is verbalize it out loud. When I'm in the back of an ambulance, hey, I've got ondansetron, whatever you call it, Zofran. You got Zofran. I got 2 milligrams per ml, 2 mLs, 4 milligrams. Expiration date is this, whatever. You go through all your things and saying it out loud. That way, if you're about to give some ketamine for pain, or you're about to give etomidate for induction, and you say, if I said to you, I'm going to give 100 milligrams of etomidate, would that kind of go... Well, hang on, 100 milligrams, like for a big guy, I'm going to give 30. That's a big dose. Are you sure? Oh, no, I'm sorry. I'm in 100 milligrams of ketamine, right? Yeah. When you're verbalizing it out loud, it's kind of going through that system 2 checklist so we don't make mistakes.
That's exactly right. And I think that's really the point of this whole cognitive bias series. Yeah. Is to really do what you just said, is to be aware.
Yeah, because we teach, all this information in our podcasts and our lectures, and we have to have the information, right? We have to continually study. And that's part of cognitive bias. There's one part of that it's like the way we're originally trained, that's how we're going to do it for the next 20 years. And no, we can't do things that way. Nope. We have to alter how we do things. And so it's very important for us to know, because people's lives are at stake. Yep. And so it's very important us to know that this can happen.
And I believe that in this industry, we're at increased risk. We're tired. We're up all night shift.
For sure.
There's a pressure to be fast. You got parents watching you. You've got your medical director on a ride out with you.
It's your 4th call after midnight, and you just want to go back to bed. Let's be real. You're tired. Yeah. Make mistakes.
So that I think this industry in particular is just ripe for falling prey to to these cognitive biases.
Yes.
And that's really what we want to talk about today. So we're going to go through the different cognitive biases, maybe tell a few stories to reinforce them.
Yep.
And hopefully at the end, our goal, the objective here is not just to be able to list them, not to be able to just know what they are, but to recognize them in your own practice. So as I think what I'd like to hear is as we go through these, that our viewers are listening or maybe watching, depending upon where you're doing this, and imagining stories maybe you've had.
Oh, yeah.
As we share stories to, maybe recognize that pattern the next time you're in that situation and maybe provide better care.
Break that pattern. Yeah, make sure that you don't make those mistakes.
Yeah.
So anchoring is the first one.
And I like to... anchoring bias is commonly used, but sometimes we don't really know what it is because there's a lot of different, very very similar cognitive biases. But anchoring, the key for anchoring is you receive information from the outside, and you anchor on that information. Yeah, dispatch says we got a 15-year-old female for anxiety or whatever. So you're immediately thinking,
this is. Yeah, let's move on. Yeah,
panic attack. Or
whatever. Yeah,
and you get
Not
there,
that
she's
serious.
short of breath, and she's breathing really fast.
All the classic signs of an anxiety attack, right?
And that's what you're thinking because you're anchoring on that diagnosis of anxiety. And I've been there. I'll tell you. I think I've told you the story before. A young lady, a volleyball player, came in, high schooler, breathing fast, history of anxiety, which is what mom said, and that's what mom thought this was. But she's just not calming down. And so I anchored on it. And before I had returned, my nurse had drawn blood already. And I remember telling my nurse, great nurse, I said, well, it's too bad you did that. I wasn't going to order labs because I'm pretty sure this was anxiety. But I'm glad you did. We'll let the mom know. And so, well, to be sure, Mom, we ordered some blood tests, just to be sure.
Yeah.
She was in florid metabolic acidosis. Well, anyway, DK.
Yeah.
I mean, she was breathing fast to get her pH up a little bit, right?
Yeah.
So she was sick. Well, I had anchored on that, and actually some of this relates to framing effect, which we'll get to later too. But the idea of anchoring on a piece of information from the outside from mom, I found the correct answer, and I wasn't going to divert from that.
Yeah. Yeah, you're not going to convince me otherwise. This is what that is. A 15-year-old girl having an anxiety attack. You're fine. We don't need to do all these things. We've all been guilty of that. I think one of the things that we can do as pre-hospital providers, especially with dispatch, is don't, like we always say, kind of putting on the blinders or anchoring, same idea, same thought. Come up with 5 different differential diagnoses.
Love it that you said
as you're going, like we do that with our escape rooms, right? Like you're en route to a breathing difficulty. Give me 5 things this could be: asthma, COPD, CHF, anxiety, overdose, right? Just 5 quick things, right? So that way you're keeping your mind open to the possibility that this isn't anxiety or this isn't, we're going on Fred the homeless guy again who overdosed on his whatever, and no, actually we didn't know that Fred has really bad COPD or Fred has really bad asthma, and we don't listen to breath sounds because whatever the case may be, right? So coming up with differentials en route will help our minds from anchoring.
That is a great tool. I love it that you said that. And I do the same thing on ride-outs. I ask my paramedic or whoever's training, give me X number of things that it could be. That's a really good exercise. And that is a great tool, something easy to do, right? You got to do something when you're en route, right?
Yeah, exactly. So besides giving directions and
great idea.
But and again, I mean, all of us, if you've been doing this any length of time, that dispatch notes, because and this isn't a shot on the dispatchers, they're only getting the information they're given, right? So a lot of the times that information is inaccurate. Again, not the fault of the dispatchers. It's just inaccurate information that we're getting. And so if you get in the habit of anchoring on that, you're going to find yourself in some trouble at some point. It's going to turn around and bite you.
So related to anchoring bias, and a lot of times, and they are very similar. It's a subtle difference, but it really is quite a bit different when you really look at it closely. Confirmation bias comes from within.
Right.
You are examining your patient, and you have decided at some point that this is asthma, and you really have it almost feels like you've anchored on that diagnosis, but it's not from outside. It's not from a dispatch. It's not from your preceptor that said this is what it is, or that this is a frequent flyer, right? Now you have decided you know what this is. And now as you continue your physical exam and get more information, you're disregarding information because you have confirmed in your mind that you know what it is. Yeah.
How do we missing that angioedema? Oh,
exactly.
It's not asthma, bro. It's an allergic reaction there, an anaphylaxis. Right. Yeah.
Wasn't there a movie? I think actually, I think it was.
Was that with Will Smith? With the Benadryl where he gets his face stung? Is that what you're thinking of?
No, I was thinking of a time when somebody came to triage or whatever, and I think it was an SNL guy came to triage in an ER, talking about his diagnosis, and then had a knife in his back.
Oh, we just watched that. Yeah, it was like wasn't it like a Russian guy, and he's wearing, and he goes up and he's very calm, and he's talking to the triage person.
Yes,
and she's like, "Yes, sir, we'll get to you as soon as we can." And he's like, "Okay." He's not worked up at all, and then he turns around to go sit down. And they're like, "Oh my gosh!" Yeah,
it's kind of a silly example, but that's kind of what confirmation bias is, where you've decided, based on your information, you have decided on your own in your mind that this is a cardiac form of chest pain, and you are stuck on getting the EKG, and you're carefully putting those leads on around that knife in his chest, and he's like,
don't even see it.
It's silly, but that's really what confirmation bias is. It's something internal.
You said something a long time ago that I'd never thought about, is like when you're assessing a patient and looking at a patient, that you're thinking of the worst case thing possible that it could be, and you have to prove to me that it's not that. And that's kind of a good way where I think sometimes, and maybe this is just in my experience, I think sometimes we get lulled into this sense of security in pre-hospital medicine that 90% of what we do is BLS, low acuity stuff. And we're looking, that's probably what it is. It's probably nothing really life-threatening. As opposed to thinking, okay, this person that's complaining of a headache at 2 a.m, like, oh my gosh. We're like, this just, we're not thinking, okay, this is a hemorrhagic stroke until you prove it to me otherwise, right? And so I think that is a good way of looking at your patients when you're assessing them is, I'm going to think, what is the worst thing this could be, and work down from there, as opposed to looking at it from, this is the least life-threatening thing and saying, yep, that must just be what it is, and let's take them to the hospital.
Yeah, I learned that from attending a medical school, and I forget that. Sometimes I forget that. Yeah. And you've been how many calls
exactly
through the night, right? You're tired.
Yes.
And it's hard sometimes to do the things that take more effort.
Right.
To approach every patient that way takes some energy and some effort, some cognitive horsepower, and you're trying to rule stuff out by asking the appropriate questions in your history so you can kind of check stuff off in your head. And then you're going to your physical exam, check more stuff off in your head. Now you've got a shorter list of things that it could be. Wow, some of those are scary.
Yeah.
Let's act appropriately.
Yeah.
Whereas it's a lot easier to kind of look for that diagnosis and then run with it.
Yes.
Yeah, and when you're tired, hungry, stressed out, burned out,
right,
it's easy to
absolutely
succumb to that cognitive bias.
I hadn't thought of this in relation to this, but it fits perfectly. And it was I believe he's from the Bryant Fire Department here in Texas, and they had a LODD, line of duty death. 2 firefighters, if I remember correctly, perished in this fire. And one of the guys came up to talk about this incident, and it was a Knights of Columbus. I believe that's what it was. Phenomenal talk. Look this guy up. He'll come to your fire department and give a speech, and for 2.5 hours, this guy talks straight. Well, you can't get firemen to pay attention for 10 minutes. This guy talked for 2.5 hours straight, never took a break, and everybody was locked in because this story is amazing. But one of the things that he said, I think he was working like a overtime shift or a trade or something like that. And one of the things he said was he had a rookie, and then he had like a 10 or a 15-year guy. And he said, I was right in the middle between inexperience and complacency. And I'll never forget that statement, because I thought, that is powerful. That's a powerful statement, because you have the inexperienced person that doesn't know what they don't know. And then you have the complacent guy, because he's been doing it for 10, 15, 20 years, thinks he knows everything. And now you're right in the middle. And it's, the new guy's doing everything, but he doesn't really know how to work it yet.
Yeah.
But then you have I don't need to put my mask on. We've been this place 10 times on a fire alarm. It's not a fire alarm. We don't need to put our gear on. I don't need to put. So this doesn't even tie into just being pre-hospital providers. It's even like being a firefighter and going to a structure fire and thinking, I've done this before. I don't need to take all the precautions that I should be taking because I've done this 100 times before and it's never turned out bad for me. Yeah. Right. And inexperience and complacency and being in the middle there, I don't know, that just kind of hit me of what you're talking about.
Well, I was at a structure fire yesterday, and I was talking to my guys about, we were just talking about rescues. Mm-hmm. You get on scene, and I told them, I said, well, it's probably good that the homeowner's out here so they can tell you, everybody's out of the house. He's like, no.
Confirmation bias.
Right. Yeah. So they said, no, because what if a neighbor went in to try to find somebody to save them and they fell and there could be somebody.
You still have to do the search.
You still have to do it.
Yep.
So I thought that was kind of interesting. You brought up fire, and again, it could be any profession, but in fire EMS, I think we're at increased risk.
Yeah, we're mainly relating this obviously to patient care, right, in the healthcare system, right?
Mm-hmm.
But it's prone to anything. All right, so we talked about anchoring, we talked about confirmation bias,
availability bias.
Availability
or is it?
Well, we got premature. What is it? Premature
closure.
Closure.
Yeah, premature
closure. I
closure.
couldn't see that word all the way.
So this is related again to both of the biases that we just talked about, but this is where you have a patient undifferentiated. You don't know what's going on. Maybe it was a altered patient, right? Yeah. Altered mental status is a classic one for this. You're going through and you got pinpoint pupils. And so you're
opioid overdose, get the Narcan out.
It's like, mic drop, I'm done.
Yep.
This is an opiate overdose.
See ya.
Right?
Yep.
And you end up being wrong for whatever reason. I mean, that you can have small pupils for lots of reasons and call them pinpoint pupils,
well,
maybe
how about
from
this?
Lack of experience.
Yeah, they start giving the Narcan. The Narcan's not working, right?
Yeah.
And so they're like, it must be a carfentanil overdose because
so
we
give
don't
them more.
So, or give them more, or no, we just got to intubate them, right?
Yeah.
What, did you check a blood sugar?
Exactly.
Maybe they're a diabetic and their blood sugar is 10.
You never, or you're right. I mean, it could be lots of things, but in premature closure, what we do is that dang amygdala of ours, that reptilian portion of our brain says, we found it. Hold on to it. We're done.
Yeah.
Mic drop.
Yeah.
Right? Well, we're not done, actually.
Yeah.
And I think that's the key to these is you're never really done. So we want to have systems or checklists in place that create a system where we complete our physical exam and we don't miss those ligature marks on the neck. We don't miss the fill in the blank, right?
Yeah.
That actually explains why the patient might be altered.
I don't know, they must do this in medical school because I see it pretty much 100% of the time when I take a patient to any hospital, any physician, you guys always come in and do a full exam. Regardless of the patient's chief complaint, you're listening to breath sounds. Yeah. You're listening to the heart. You're, assessing mental status. You're doing all those things. We're not really trained. Like, I'll be honest. I don't listen to breath sounds on every patient. I should, but I don't. Yeah. Usually if it's applicable to what's going on, if they're complaining of shortness of breath, right, then I'll listen to breath sounds. But if somebody has a seizure, I don't typically listen to breath sounds on that patient. If it's an altered mental status, maybe an opioid overdose. But I do notice that, again, almost 100% of the time, physicians, and they must have taught you this in medical school so you don't fall into this trap.
Well, I'll tell you, I've had my head ripped off a few times as a student with the way that the culture is with being taught things. There's a culture of ripping your head off so you never do that again.
Well, that's a culture in the fire service too.
Is it too? Okay. They actually call it pimping in medicine. Yeah,
really?
The art of pimping. There's an article on it. You could read it. It's in literature. The art of pimping. It's being an attending that knows how to pimp. And what that means is you know how to ask questions and really get the information you want out of your. When I was an attending up north of us here in a medical school, I had a group of baby doctors, and there's a certain art to they call pimping, I guess. And,
Okay.
and it's about asking questions and really drilling people to the wall if they're not prepared.
The students,
or if
okay.
they make a mistake, or it's almost like you just keep asking questions until they don't know something, and when they don't know something, you nail them to the wall.
Yeah, we call it hazing.
Hazing.
In the fire service.
That's really what it is.
Yeah, okay.
And it's the culture of medicine. That's how we have all had in medicine those attendings and those people that do this, and it's just
Didn't
the
you tell
way
me about some attending you had that made him? You had to carry him around in a chair or something like that?
Yeah, I had an attending that we pushed him around in a throne.
Oh,
on
is that what it
wheels. It was a huge. He's actually a great guy, one of my favorite cardiologists, but he demanded a lot, and he created this whole aura of "don't mess with me. You better have your crap together." And anyway, I've got a lot of stories there, but with I guess as we talk about premature closure, though, with this, it's easy to just stop and think you're done, and we don't move on, and that's a bias we don't want to fall prey to. We want to complete it, have your system in place, do your thing, get her done, and keep your eyes open. I think that's what we want to do. I think that system or those checklists would be a good way, like a trauma. You have a way of doing your trauma assessment.
Well, and your secondary assessment, right? You always do a secondary assessment first off, you do that rapid assessment to look for any life threats, right?
Yes.
Then you do a full assessment, but then you do a secondary full assessment to make sure, did I miss anything?
What's the most commonly missed diagnosis?
The second.
That's right.
Exactly.
So you get that pneumothorax on your trauma patient and you think you're done. Premature closure. Well, you're not, because you didn't finish your exam. You missed the broken femur. So that's good. The next one, availability bias. This is when you have that common or really recent experience that influences you in the current experience. And that availability bias can be dangerous too in different ways. You just had that pediatric cardiac arrest.
Just took a class on something.
Exactly.
Yeah.
And now you got this kiddo that's actually pretty healthy who's screaming, and you're thinking, they're about to die.
Yeah, right. We got to intubate this kid. No, he's just mad.
No, he's just
Calm
mad.
down. Yeah, that's very, exactly. Like you say, you run a call or you take a class, and then it's availability bias. I kind of put towards, what was that other? I got to look it up on my phone. Give me a second. It's just so I can remember. Yeah, it was the when you're looking for a car.
Yes.
And I want to get it right.
It's like
here.
Baader-Sluger or something.
Yeah, Baader-Meinhof. The Baader-Meinhof
Meinhof
phenomenon, or frequency illusion,
Yeah.
is that illusion of, like, you know, you're looking at a red Mustang, right? You're thinking about buying a red Mustang, right? Or a black pickup truck.
Yeah.
And as you're driving down the road, all you see is red Mustangs, right? And it's that same kind of a thing, right? Availability. It's, to me, that sounds very much.
It's amazing how often that happens, and you're absolutely right. Somebody talks about something you've never seen before,
right,
or you never experienced, and now it happens all the time.
Yes,
it's that's interesting.
Yeah.
We're just not aware of it until we.
It's
hear
amazing
about it,
how the brain works.
It is
really amazing how it works.
We should do another podcast.
But we have to learn to use it to our advantage.
That's right,
and that's what we're talking about. And that's why checklists are important, right? Framing effect.
And so this is when the context or, information of the scene creates a frame around the picture that really dictates what you see.
You got a car wreck.
Yeah.
Patient's unresponsive in the car wreck.
Yeah. And it's a trauma. So you're just thinking trauma.
Exactly.
And it makes sense because of the context. But if we keep our mind and our blinders off, we realize this car accident actually happened. This guy was on his way to the ER with chest pain. He's having a STEMI and he passed out or whatever, right?
Yes. Exactly.
Still could be traumatic injuries, but it's important to not be influenced by the context.
Yes.
That's the framing effect. Pretty basic, but very dangerous potentially.
Yes. Yes.
The next one we got is overconfidence bias, where, gosh, this could really be with any of them, Matt. Where you're so confident in your abilities.
Listen up, senior nurses, medics, and doctors.
When I was checking off a guy that signed up with my department, I had to check him off, even though he had a ton of experience. And he was super smart, and he did really well.
Yeah.
And I told him at the end, what you're going to need to work on is maintaining humility and the desire and the curiosity to just keep learning.
Yes.
Because you're going to, you know your stuff so well, you're going to feel like I've arrived.
Yes.
Well, none of us have.
There's nothing else I can learn. Yeah.
The more I learn about the human body, the more I realize I don't know. It's humbling and it's beautiful.
Yes.
So I think with overconfidence bias, I think what'll happen is you're so confident you know what's going on, and you're so confident in your abilities. You do your neuro exam, and you do a truncated one because you're just so confident, and you didn't do everything you normally do.
Yeah.
You're just trying to get through it, go through the motions because you know what's going on.
Yeah.
I'm an experienced paramedic.
Yeah.
Right. And you miss something.
Yeah. I think we've all
been there.
Yeah, we've all done that.
And you know what's really bad is that not only have we been there, is I have done it countless times, and never did I have an ill effect from it because I was right. It's that 1% of the time when you're wrong. That's what's dangerous. And that's part of what cognitive bias is it's not about being right every time. Right. It's that 1% that you're wrong. It's the scary one.
Yep.
And you know, in your career, you may be okay and get lucky every time, but you probably won't. No. There'll be one time, and that's all it takes.
That's right.
Yeah, and that's when we can get in trouble and cause harm.
And that's where you said it at the beginning, ego, overconfidence is a big problem with ego. Definitely a problem in the fire service, not going to lie.
Yeah.
You know, because, you know, seniority and tenure in the fire service is such a big deal.
Yeah.
And, you know, I'm a 5-year guy, I'm a 10-year guy, I'm a 20-year firefighter. Nobody's going to question me, right? And, you know, I've been humbled before training as an FTO, training new paramedics. And I've had some really smart guys come through, way smarter than me, where I've been in the back of the ambulance and they've said stuff and I was like, oh, I didn't think about that. You know, and I'm supposed to be the guy training the guy, right? Yep. There's a good friend of mine. I don't think Mike Miller, works for the McKinney Fire Department, one of the smartest guys I ever trained. And I remember being on calls with him, and he's just a smart guy. Uh-oh. There it is. He's just a super smart guy, right? And he would say things, and it wasn't that I didn't know what he was talking about. It was that I hadn't even thought about that. Yeah. And so especially, I'm talking to my FTOs out there. Don't think just because you have an FTO by your name that you know more than that new person. That new person just came out of school, and they might have got the most recent information that you don't know. And so be humble and be open to have those conversations and listen to what they have to say, because they might just surprise you and be like, oh, I hadn't even thought about that. Let's do that. So anyway, I'll get off my soapbox.
No, well, that's great experience, and that's what this is all about, is being aware of it. That's right. So we don't do it again. Diagnostic momentum. I think this is classic in my mind. And maybe you have a different story, but I think of those transfers that I have been a part of with some of the agencies that I've been medical director for, that was most of their business was interfacility transfers. You take a patient who's gone through a whole big long workout. Sometimes they've even gone through a long admission, and you're picking them up and transferring them to a new facility. And you know the diagnosis is sepsis.
The doctor and the nurse told you.
Everybody.
And you're an EMT thinking, what do I know compared to them?
Yep. And so you have a problem en route during your 30-minute transfer, and something comes up, and maybe the oxygen levels go down. You think, oh, well, it's just from the pneumonia sepsis that they have. And you're looking at that number go down, and wow, must be a really bad pneumonia, and you're looking around. Anyway, you fail to recognize the fact that you're having a equipment failure with the ET tube that's leaking, an air leak, or who knows what. Yeah. But the point is that there can be a lot of diagnostic momentum. It doesn't have to be a transfer. It could be something where you've gone down this path of treating this trauma patient for all these things. You've intubated them, the chest tube, the finger thoracostomies, all of the trauma treatment you've done. There's a lot of diagnostic momentum going down that path. Yeah. And it's easy to miss something that's not part of your trauma assessment. This is,
I would say, one of the most common pitfalls with this is SVT and WPW. A patient that we had. We talked about this.
Yeah.
And we went on that call, and every paramedic in that room was convinced this lady's in SVT. Yep. They're pulling out the adenosine. They're getting the defib pads ready to cardiovert. And well, hang on. Yep. First off, and this is something for every paramedic, EMT to think about, they're stable. Let's slow down.
Yep.
Let's slow down. We don't need to be in a rush here, right?
Reassess.
Let's reassess. Let's look a little deeper, right? Because could this be something else? Yeah. And once we looked through the EKG, it couldn't confirm, but we couldn't say for sure that it wasn't WPW.
Yep.
And I remember I called you on the phone.
Mm-hmm.
And here was the thing, and we're going to talk about action bias later.
Yep.
But here was the thing, is that sometimes the best thing to do for your patient is to not do anything.
Right.
And I feel like, we'll talk about that with action bias, but this patient was completely stable, alert and oriented, blood pressure was fine. The only thing that was out of whack was her heart rate was high.
Yeah.
And we couldn't say for sure it wasn't WPW. And so I remember I called you and I was just like, let's hold off. Let's give her an IV. We can give her some fluids. That's not going to hurt her. And we need more information. And I'll never forget coming into the ER and you were in the same, I can't confirm it either. And you're on the phone with the expert of experts, right?
Yeah.
And what did he tell you?
He said, go for it. This is not a big deal here. In this particular situation when he saw the EKG.
He knew it was this patient.
Yeah.
Yeah. And it was WPW.
Yep.
And he said, don't give her those medications. It's not going to work on her. So anyway.
That was it's a perfect example for this, where you feel like you've got all this momentum behind you.
Yeah, it's got to be. I'm all excited, right? Yeah. Especially as a new provider. I've never given adenosine before. This is going to be cool. Hang on, slow down, cowboy.
As you're telling this story, it's a perfect example of how some of these biases can compound on each other. Mm-hmm. You've anchored on something, and then you develop a bit of diagnostic momentum behind it. It becomes harder to unanchor.
All the other people around you are going, yep, that's what it is. It's SVT. Heart rate's 170. It's
And then on top of that, you get the other bias, like you mentioned, the action bias. I suppose we could skip ahead and just mention that one.
I think it's fitting,
It is, because we have a tendency, a bias, to want to do something.
Yes.
And that makes good care.
Yes.
Well, sometimes good care is not doing anything at all and recognizing the fact that nothing is needed.
Right.
And that's the best thing for the patient. But we have this cognitive bias, this action bias to do. Yes. And that's really good to recognize.
And I think, I think the other part of it too is that you're as an EMT paramedic, you're thinking, well, my medical director is going to QI this report and be like, well, why didn't you treat this heart rate at 175, 180? Yeah. Why didn't you treat this? Why didn't you do anything? And so, as long as you have an explanation as to why, that shows you're a thinking EMT, you're a thinking paramedic, nurse, physician, whatever it is. Wait a minute. I didn't just jump to a conclusion because of overconfidence or confirmation bias from the crew or the dispatch notes, right? Yep. I was thinking through the problem on system 2 thinking that, well, wait a minute, this could go bad if I do the wrong thing here. Yep. Anyway.
Well, that leads us to the next one, search satisfaction. There is a certain amount of satisfaction that our brain gets when we find something.
Yes.
And we want to maybe anchor on that or maybe develop some diagnostic momentum behind that. But there's something that we need to be aware of is when we do find an answer, that is satisfying. And that cognitive bias can interfere with the care we deliver. We have to continue. We don't want to stop early like we talked about a bit ago. Yep. We want to be aware of the fact that finding a diagnosis gives you that cognitive bias of satisfaction. And it's tempting to stick with it.
Yes.
But we have to maintain our open mind and take those blinders off.
Yeah, I think that's probably most prevalent with trauma.
Yeah. Is
some of the most horrific wounds and things that you see are probably not the life-threatening ones.
Right.
It's the stuff happening in the thoracic cavity or the head that's probably going to kill them faster than that massive tib-fib amputation or, angulated fracture or whatever it is. But, oh, my gosh, that's so nasty looking, and you're missing the fact that your patient has a collapsed lung, or something like that. Anyway.
You missed the second diagnosis.
Exactly. All right, Dunning-Kruger.
Well, this one's an interesting one. I think this is different than all of them. I think this is one of those unique ones to me personally that stands out a bit more. Mm-hmm. And it could be a procedure. It could also be a certification, a new level of function. Maybe you just checked off by your medical director to be your paramedic
finger
in your community.
thoracostomies or whatever.
A new procedure. In fact, I just taught our department's getting into POCUS, or point of care ultrasound. Yeah. So I just signed everybody off on being able to do fast scan in a trauma context when appropriate.
Yes.
And I think we're pretty excited as a department, but we're on Mount Stupid.
Yeah.
I don't mean that in a derogatory sense.
It's literally what they call it.
Yep.
Yeah.
And I don't think it's bad either. Just we need to be aware of the fact that we're going to have, like we talked about earlier, the confidence is going to grow faster than the competence.
Yes.
We're going to have a lot of confidence initially in our fast scans and using the ultrasound probes.
Yeah.
And then we get a 400-pound patient.
Yes.
Or then we,
oh gosh,
wait a minute, which way do I put the probe?
Yeah.
You know,
where does that blue dot go?
Yes, the competence takes a little time, and I think
Takes
that
reps.
when we're rare, and so again, it's not just procedures. It could be I just became a doctor. I remember. Here's a story. I had been a doctor for a week, and I'm in a plane, and the pilot's asking me for information to turn the plane around or whatever. So, as a new doctor, I remember feeling like I could do this. Right. I mean, I made the right decision, fortunately, but initially when I became a doctor, I've got this.
Yeah.
I have learned so much since then. I had no idea what I was doing.
Right.
I was on Mount Stupid.
Right.
But now with experience, I'm more confident. But I got to be careful, right? I got to stay humble and know that I need to learn more. And you can never rest your laurels on what you got. You got to always keep an open mind.
Well, that's the beauty of experience and education. Those are the two elements that make you a good paramedic, because when you come out of paramedic school, you know, most of the new people that I train, or EMT school or paramedic school, they struggle with assessment because they've never done it before. So they use their checklist. They use sample history. They use OPQ or ST. They use these acronyms that we pound into their head in school so that they don't miss anything, right? But then, you know, you've been doing it 3, 4, 5, 10, 15 years. You don't use sample history anymore. I got my flow down, right? But it's a good thing to have that checklist, just like we talked about, the 6 R's of medication administration, because it can turn around and bite you real quick. Right?
Especially if it's a chaotic scene and there's a lot going on.
Yes. Or a very complicated patient.
Exactly.
Yeah. Super sick.
Those things can all complicate it. We talked about the action bias. Authority bias is an interesting one too.
I'm telling you it's this.
Right.
Yeah.
Well, you're my boss, so I better listen.
Yes. Yeah.
I'd rather.
You're the doctor. I better listen. You're
right.
Yeah.
No, I've been there. I've been a medical student who I was in Southern California where I trained in medical school, and I was watching my senior resident do stuff, and I remember thinking to myself, I just learned something, and it looked a lot like what I was learning, and I wanted to tell that senior resident, hey, you should check this, right? And I
want to get your head chopped off,
right? But I didn't want to say it.
No,
but,
gosh, no.
But I knew that he was missing the mark. I knew enough to know that he was kind of going down the wrong path.
Yeah.
Anyway, but because of that authority bias, and in a reverse way, I didn't want to say anything because I was afraid of, you know, this particular senior resident was a bit intimidating to me as a medical student. Same thing can be true on the flip side, where your boss or your preceptor or your medical director, whoever it is, says something about a diagnosis, and you run with it because they said it. You're not even thinking. You just follow along.
It's easy. It's
exactly.
Dr. Axine told me this is sepsis. I'm going down. Get out the cefepime. You know.
Dr. Axine said anxiety. We don't need blood tests.
Exactly.
Fortunately, that nurse did not fall prey to authority bias.
The checklist. What are you supposed to do? Yes, exactly. Do your trending your patients, right? You know, you think that original patient, when you show up and they're complaining of chest pain and you run the 12 lead and there's nothing there. You know, it's probably just gas or whatever, angina, whatever. It's nothing, you know, and then you don't do a follow-up 12 lead. And then they get to the hospital and they do a 12 lead and they've got this big STEMI going on. Like, oh, I haven't done a 12 lead in 20 minutes, right? Do a follow-up 12 lead. Hey, how's that chest pain doing now? Has it changed at all? Right? What else are you doing in the back of the ambulance? Reassess your patients.
Exactly. Well, the last one, our 12th one, we've gone through 12.
Suck.
Cognitive, the suck bias.
Suck bias. Don't suck.
For those of you listening or watching, I misspelled. Actually, it wasn't misspelled. It was suck.
Suck was spelled correctly. It just was the wrong word.
Thinking.
When I was looking through this PowerPoint, I'm like, what is suck bias? That's a weird one.
What I meant to say was sunk bias. So sunk bias, I think actually our media director, Devin, had a great story on this one.
Yes.
With his daughter brought to the ER, and they were a baby, little infant, his daughter, and they were having trouble with the IV, and they had tried so many times, all this sunk cost into getting an IV. That's all they were.
Over and over,
That's right. So the cognitive bias now of sunk cost. I've tried so many times and I've invested so much time. I'm going to get this, dang it, right? And then his wife said, if we needed fluid, I could breastfeed the baby if you'd like.
There's other ways, yes.
And so they said, oh, yeah, I guess we don't need the IV after all those pricks and pokes,
Yes.
So anyway, but the same thing could be true for us. We put so much effort and intellectual, capital into this decision to do something. It's like we feel like we've got so much sunk cost involved in this.
I can't not do it at this point.
It's almost like diagnostic momentum in some ways. Where because I've invested so much and because I'm so far down this path, I'm going to stay on it.
Yeah.
And that is a cognitive bias that we really need to be aware of too.
Yeah, for sure. And I think that we definitely, it's so funny if you'll be in the fire station and you're working on something or fixing something and you can't get it. Every single fireman in that building is going to touch that and do the exact same thing that you've done 10 times because they're all like, nope. He couldn't get it, but I'm going to get it. And then he couldn't get it, but he's going to get it. And it's just, why don't we just, sometimes, I get that way when I'm working on something at the house. I don't know if you're this way too.
Well, I probably am.
And it's like, I'll get so frustrated trying to, whatever it is, trying to figure out where this thing is or where this part is or how to get this part off. Yeah. And sometimes it's like, you know what? I just need to walk away for a minute. Yeah. I just need to put the tools down. I need to walk away. I need to clear my mind, come back with a fresh perspective and relook at this problem.
Yes.
Right. And usually when I do that, something that I was struggling and getting mad for an hour, right, and couldn't figure out, I take a 10, 15-minute break, come back. It's like plain as day, like, oh, there it is right there. Okay. Totally missed it because I was so focused on being frustrated, and so it's like, you can't get the IV on the kid, whatever it is. Just take a break. Yeah. Do we really need the IV? Like, ask yourself that question and go from there. But yeah, it's sunk bias, not suck bias.
Not sunk. Yeah. Not suck, sunk.
Yeah.
Yes. You don't want to suck and do sunk bias.
That's right.
So, Matt, I got a cool way to end here. I'm going to tell you a couple stories, and I want you to try to dissect the stories into the different biases that you see.
Okay. I'll do my best.
Excuse me.
I won't be overconfident.
Yeah. Keep an open mind. No, I think all these stories and any story you can tell where your brain played a trick on you, I think you could probably find a handful of different biases that work. These usually don't work in isolation. They usually work together.
Right.
Yeah. So I was a doc. It was late at night, and I had a patient that was being transferred to me. And the doctor at the previous hospital had said he was transferring me a patient in status epilepticus, so a patient with a lot of seizures. And so I accepted the transfer. Patient got there a couple hours later from some outlying rural place.
Hopefully still
older
not
lady.
seizing.
Pardon?
Hopefully still not seizing.
Intubated and no longer seizing.
Yeah.
And got there to my facility. And the temptation for me was to get this patient admitted to the ICU that was intubated. So far, what are you thinking? What am I at risk for?
A couple of things. Anchoring. You're anchoring on the diagnosis that he gave you. Authority bias. This other doctor told you this is what it was. What else do we got? You've got confirmation. Let's see. Availability. I mean,
I think
framing even.
I think you hit the nail on the head with what you said. Actually, I wasn't even thinking about some of the what did you said? Anchoring and what was the other
anchoring.
one?
I would say the top two would be anchoring and authority bias would be my top
authority.
two.
That's good. Yeah. Well, I think, and so here's what happened.
Head board.
So I got this patient. No, it was meningitis actually.
Oh,
she was seizing because of an infection. She had not been given antibiotics appropriately.
Didn't draw the proper lines.
They got antibiotics to kind of stop the clock, but she was in florid sepsis from a bad CNS or neuro infection. She had meningitis, and this lady was seizing because of her meningitis. Yeah, she was a pretty sick lady, and then we all had to do the prophylaxis because this lady had been, intubated with. That's a bad infection you want to identify early. Anyway, so that was where I had been receiving a patient. The diagnosis had been given to me. I wanted to just run with it, get him admitted quick, and then not think about it.
Right. I don't have to diagnose this patient. They've already been diagnosed by a doctor.
Yeah.
What do I got to do this for? Yeah.
But fortunately, we were able to get what we needed to get. But anyway, so that was an interesting one. Here's another one.
Okay.
I think I've told you the story before. It was in prolonged extrication. The copperheads were in the ditch where this truck had rolled over, and it was because of the copperheads in the ditch. There was a delayed extrication, and this patient came into the ER with mangled legs. I mean, just his legs were, and there was another problem with the extrication. I mean, his legs were just mangled up under the dashboard. Mm-hmm. And so he came to us with his legs in a box, basically, with, open fractures, blood everywhere. Mm-hmm. And I anchored initially on those legs, thinking, I got to get this guy to the OR with an orthopedic surgeon. Fortunately, I continued my exam and found that the patient by history was coming to the ER because he was having chest pain. Mm-hmm. He was on his way to me anyway. Mm-hmm. And he, on his EKG, it showed STEMI. Yep. Good thing I didn't anchor on the legs because he was having a STEMI. Well, I wasn't done yet. I finished my trauma assessment. He had a bunch of belly pain. Mm-hmm. He'd actually fractured his spleen. Oh. And so I had to get him to the cath lab to get his spleen embolized. Otherwise, he would have died before he got to the cath lab for a heart thing, or the OR for his leg thing. So a great story about, I mean, just the copperheads alone make you want to anchor on the prolonged extrication, right? And then the legs in a box. Right. So to me, there's a lot of different biases at play here, but I think for me, it was my confirmation bias, I would say. I don't know if you agree, if there's anything else you see, because it wasn't necessarily the information I got from the outside. It was when I saw the legs in a box. Well, I was tempted to anchor on what I saw.
Diagnostic momentum, right?
That
You're
true.
seeing the legs in a box. You're thinking this has to be a trauma. You're not thinking a medical issue, right? Yeah, we recently had a case like that where car off the road, MVA, showed up, patient in cardiac arrest. I was having a massive heart attack and drove off the road, right? So,
I remember you told me a story once of an altered elderly patient who was, I think, maybe just feeling a little weak, and you almost even didn't get the EKG. And it ended up being a big, bad STEMI.
It was. And there wasn't, this is a prime example of not, and I'm not trying to toot my own horn, this is an example of not anchoring on anything and not just dismissing, this is nothing. Yeah, it was an older lady right during COVID, heart of COVID, like April, May of 2020. Yeah. Called us out for generalized weakness. Get there. I'm training a new person. Lady's awake, talking to us, A&O, GCS 15, no priority symptoms. I just don't feel real good. I just been feeling really weak the last couple of days, And I'm thinking she probably got COVID, even though she didn't have a fever, nothing like that. Get her out to the med unit, and I'm letting my new person, do their assessment, go through all their things, and literally everything's fine. And I said, you know what, we've done everything else here. Let's run a 12 lead. Yeah. Let's run a 12 lead. And she was having a massive STEMI.
It's a great example.
Yeah, of not anchoring or not. Yeah, just do everything at your disposal.
We didn't tell enough stories like that where we did the right thing and we didn't anchor or we didn't have the confirmation.
Luckily,
bias.
I had a new person there to say, if I'd have been on my own, I may not have done that. I might not have run a 12 lead on her. I'm like, I'm going to take her up to the hospital. She's not feeling good. She's feeling weak. Okay.
There was this is funny. You just remind me of another case. I was on a ride out, and I thought I was doing the right thing by teaching the guys about anchoring. Yeah. And so we initially got there. The wife was telling us how he just got discharged from the hospital with a bad urinary tract infection.
Septic.
We see the bag on his leg, smells like bad urine. Yeah. He's tachycardic. He's febrile. I mean, everything is pointing towards this diagnosis of a UTI. We got to get him back to the hospital, right? So we're thinking. But I noticed blood around his lips, like dried blood. Like, I see, this is where anchoring is so important, to not anchor on the sepsis and go for I anchored on the GI bleed. That wasn't what was going on. We got to the ER and they got a CT scan. The guy had this massive necrotic appendix. Ended up being a bad appendicitis. That's why he had the fever. But what was funny is, like, en route, so funny. I can't believe I did this. Not joking. I mean, crap you not. I am in the ambulance lecturing my paramedic and his partner on not anchoring, right? Yeah. And every bump, the guy's like, oh my stomach.
The appendix.
Like every bump.
You're
like,
missing it every time.
Buddy, keep quiet down. I'm trying to teach these guys about not anchoring. I didn't actually do that.
Right.
I did reach over and push on his belly, and it wasn't that tender, so I thought, well, it must not be
Didn't
that.
hit his foot.
So let's keep talking about anchoring, guys. And then sure enough, there was a lot going on in that case, but it was kind of funny though.
Yeah.
Even an experienced ER doc can kind of just get stuck sometimes, and it's because our brain has these cognitive biases that we can get trapped in, and it's important to be aware of them. And I really like what we did for the lecture for this, in talking about the bias zone, like the Twilight Zone. You know, I think it's easy to get kind of enamored with our own ideas and our own thoughts, and that's dangerous.
Yeah. Well, it's a good talk, something to be aware of for sure. Don't get overconfident, stay humble,
and don't forget to take your assessment questions.
That's right. We'll see you on the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.